We occasionally see the development of neuromas after palmar-digital neurectomy, and these are associated with unpredictable, severe, transient forelimb lameness. The horse may take 3 or 4 really lame steps and then appear sound and not show further lameness during a work period, whereas in other horses, lameness may fluctuate during a work period. In most horses, there is some degree of reactivity to palpation over the cut end of the nerve. And in the majority, the problem is resolved by local infiltration of local anesthetic solution around the cut end of the nerve, and local infiltration with corticosteroids usually results in resolution of the problem. However, this may be have to be repeated up to 3 to 4 times for successful resolution. The neuroma can be identified ultrasonographically. Here on the right, we see a normal nerve identified by the capital N on the left image and an abnormal enlarged nerve on the right of variable echogenicity. Synovial seals, acquired outpouchings of the digital flexor tendon sheath, can be seen as incidental clinical findings. And when they're incidental, they are generally soft and fluctuant on palpation. However, if firm because of pressure due to the amount of fluid within the synovial seal, they can cause episodic lameness. And to prove that they are the cause of lameness, one can inject local anesthetic solution into the synovial seal with resolution of the lameness. They have a characteristic fluid-filled appearance ultrasonographically, as seen in the image on the right. We occasionally see mobile fragments that can cause episodic lameness. In the horse on the right, we can see that there is flattening of the lateral trochlear ridge, indicated by the large arrow head. Double arrows indicate a small osseous opacity, linear in shape. This osseous opacity was highly mobile. Lameness was not apparent in hand, nor when ridden in working trot. Lameness was only apparent in medium trot when the horse was ridden, and that lameness was abolished by intra-articular anaesthesia of the femoropatellar joint. The horse was treated surgically by removal of the fragment. However, the highly skilled surgeon who performed the surgery was very exasperated when he performed arthroscopic evaluation. This mobile fragment repeatedly disappeared from view, and after 1.5 hours, the fragment had not been removed. Surgery was therefore abandoned on that occasion. On a second occasion, the horse was placed under general anaesthesia, a radiograph was acquired, the position of the piece, the osteochondral fragment, was identified, and via an arthrotomy performed over the fragment was easily retrievable. This is an example when a horse actually exhibited bilateral hind limb lameness, but the owner only recognized this when one hind limb was lamer than the other. This is a 12-year-old warm blood mare with a history of an episodic grade 6 out of 8 left hind limb lameness. The horse at the time of examination showed a grade 3 out of 8 left hind limb lameness when ridden. Intrathecal analgesia of the distended left hind digital flexor tendon sheath resulted in right hind limb lameness. The right hind limb lameness was also abolished by intrathecal analgesia. And we can see ultrasonographically that there are large defects in the deep digital flexor tendon in both hind limbs. This horse was treated successfully by injection of mesenchymal stem cells. So my take-home messages are: knowledge of the potential causes of episodic lameness facilitates diagnosis. It may be necessary to arrange to evaluate a horse at a competition or the following day, or after an intense schooling session.